friends. I know it's the back end of the day, so we will try to be very brief. I represent the Ministry of Health and Family Welfare, where we are after monitoring and evaluation of the health programs, and in particular the National Rural Health Mission. What I'm going to present to you is something that we have, established in the last 1 year, and we call it HMIS. HMIS, widely used but widely misunderstood. Is it hospital MIS? Is it health MIS? What is it? How is it? And how does the government work with it? Well, if you look at the first caption on my slide, is Ministry of Health and Family Welfare. Now, a large number of problems starts with all the alphabets in that, health and family welfare. Most of the problems start with the ampersand, because traditionally health has been seen as vertical compartmentalization of various programs, and that compartmentalization, those vertical silos, drill down to the lowest level functionality. As a result of which, we have not been seeing too much of and, but it's or. So what we tried to do from this health MIS perspective was to create an empowerment media, and this is what I would just like to just portray the small effort that we tried to make in trying to make information more available to the public. This is the HTTP address, the web address of the portal. This is available in the public domain, and it's available for any user in the government, in the private. Any citizen can see the information on it. Now, in the morning session, we had an idea about the National Rural Health Mission. Sorry about this, a mistake. It's 2005 to 2012. But just to give you an idea of the perspective, we have over 2 lakh public health institutions, more than 600 districts, 35 states and UTs, and 75% of the population is rural. So that's why we have a National Rural Health Mission, trying to get the different components together, to work together, to get the systems functioning which were not functioning, or perhaps functioning in disparate directions. We also found that very little attention was paid to data, information, use of information for action. There was always manual preparation of reports, and in the process what happened was, you talk to any person down the public health infrastructure, they'll say, what are you doing? I'm filling up reports. I'm submitting returns. So we found that a huge amount of systems were bogged down by this information overload. What we did as part of the National Rural Health Mission, we created a program management unit in each district. Now the program management unit was all contractual, where you had a management graduate as a district program manager, you had a MCA as an MIS officer, you had a chartered accountant for looking after accounts. All these 3 support functions were to help the chief medical officer of the district or the state, wherever he's functioning, to support the secretarial work which is required. I would call it secretarial because it's a staff function, but it's critical if you want to really deliver your goals, attain your goals. So we felt there was a need for a real-time monitoring system and a decision support system which is not sustainable. India is a country where we have a large number of pilots but very few planes. So we always have pilots, they take off, collapse, and vanish. So sustainability was the criticality of the system, and that was the harbinger of a change in the government. As I said, we have been living with compartmentalization and vertical silos. We have also had several programs over the years, over the decades, where there were a lot of reporting requirements. Those reporting requirements remained even though the program may have outlived. So those forms and formats continued. What we did was we undertook an exercise last year. In fact, last 2 years we've been trying to rationalize the forms based on the utility levels. in the process, we shifted a huge amount of the monthly reporting to the annual reporting. Things which would not change over time, we shifted that to the annual. And we also found that because of these, en masse number of forms that we had, there was delays in reporting and we could never get reports out on time. More important was capacity building on monitoring and evaluation. As I said, we have established these program management units in most of the districts in the country, training them into the goals of the mission, into the goals of the health sector, because they are all contractual people, they had no health knowledge. They were not in the domain. They were domain experts in their own field, but not in the health sector. So we had to get them trained. Training is an ongoing process. Being contractual positions is a huge amount of turnover also. Attrition. We had workshops, national level, regional level, just to get something. But more important is that we laid down certain systems. We also established a clearinghouse on information. This clearinghouse on information is chaired by the Union Government Secretary of Health. He cleared all requests for additional information on the load. So any additional information required by the central government, it has to be cleared by this clearinghouse. Only then it will be added onto the burden. Because as I said, we have 2 lakh institutions. Any additional item means that much of a multiplier. We've had detailed discussion with the various stakeholders, tried to rationalize the forms format, and then finally sent it to the states last September. Now the focus area of the rationalization process, the reason I'm going through this is that it's not that we have been sleeping, it's just that we have not been thinking in the right direction. We have, initially we were talking about state level reporting. In the process of state level reporting, the district level performance gets averaged out. Similarly, at the district level, the block level information gets averaged out. At the block level, the facility level information gets averaged out. So what we did in the rationalization process, laid down this is the minimum requirement of data required for each facility and how they will report of the structure. We minimize redundancy, create a certain definition, glossary, and we envisage that the block headquarters, that's around 6,000 plus blocks, where they will be the hub for the health MIS. Now, as I said, we had MIS for various programs, whether it's TB, malaria, NRHM. We also laid down certain things that we will have a nodal information officer at various levels, at the state level, at the district level, and at the block level, whoever needs it. So that these people would be functional, they will get data from all the programs with the repository of information and transmission. This is the broad flow of information. You have the health sub-center at the periphery level where you have around one sub-center manned by an A&M, a health worker also, covering about 5 to 6 villages on an average. Then you have a primary health care center covering about 30,000 population and so on and so forth. This is how the data flows up the system. This portal was launched in the month of October last year. This is the address. This is just an idea of how the portal looks like. But this is perhaps the first time that we created a dedicated portal for the health-related information. Right now we have started only on NRHM. As I said, we can't afford to go on for too many pilots. We have to go nationwide. We started for NRHM at the beginning. Now we're going to gradually integrate the reporting requirements to various other programs. The other thing is we discontinued paper reports under the NRHM. So we now will rely only on the data put on the portal. Single source of information, so there will be no disparity. In the process, we also learned that India has got 643 districts because we had to give user IDs to each of the district users. The web-based data capturing system, as I said, connectivity is an issue in various places. So we have a system of online as well as offline entry. It can be done, need not be done in the office, it can be done from a cyber cafe as well, provided you have the forms and the data and you can upload. It also includes district level financial monitoring reports, which is unique because till now we have only state level reports. So you could match the physical and the financial and see how you can plan out your activities. It provides for a lot of interconsistency checks. identifying outliers, since it's a huge paradigm change in terms of way of reporting, is a huge learning process for all the people in the health system. And aggregation, of course, is not an issue. You can prepare standard reports, customized reports, depending on the requirement, both for the health, the people in the health system as well as those outside. What we do is that, obviously, that there is so many institutions, so much of information coming in the system, there would be some issues on data quality. We have tried to provide in certain checks where the user, before uploading the data, he can verify, cross-check, look at his outliers, find out whether he can confirm that the data is correct, find out how much of data he's filled up, and prepare reports and check through monitoring visits. Now, when you change from a manual to a web-based system, you always have that issue of who is going to see my data, who is going to be responsible for it, and should I be responsible for it? We are trying to percolate a culture where the generator of information are the owners of information. So that if the district level has entered the data, they are the originator, they are also the owners. No one else can change the data. Only they can do it. If the state finds out that there is a problem in the data, they will go back to the district and get that corrected there. Similarly, the state will see the data and then send it to the center. Once it reaches the center, it's available in the public domain. Anyone can see it. Till then, it remains provisional. We monitor the day-to-day reporting of which state, which district have been filling up data, past, current. And as you can see that we started in the month of October, but we insisted on data from April 2008 onwards to be out of the system, so that you can do comparative analysis. Analysis, there is no end to analysis, provided you have data. The login users, the authorized users can compare the data across district, across item, across periods, across sub-district. I mean, it's endless. Analysis is endless. And we are also making this as a portal where you can get all health-related demographic information as well. We have a large number of surveys data that is also available on this portal under the periodic publication. All the MMR data. So basically, if anyone wants data related to the health sector, they can approach this portal, get data, whatever is available, and in the public domain. See, one of the hallmarks of this UPA2 government is to ensure transparency, openness, and in the process, when public gets this data, we expect that they will be able to talk to the health professionals and counter. If the report has said 5 deaths in the district for this reason, go back and check with the health authority. Is it correct or not? So this is the power, this is why I say it's an empowerment media for not only the health sector, but for the public at large. So for the year 2008 and 9, around 95% of the districts have already submitted data. It's available on the public domain. We are in a constant dialogue with the states to make sure that the data is correct and it can be released to the public. Now this has grown in the last few months. We have seen about 5,700 page views every day. In fact, it's IBIS interest in other international countries, countries where people are wanting to learn from the Indian experience. 34 countries have already seen how we are performing, and it's a huge power. But the main challenges ahead, and which will remain a challenge, India being a huge country, is training. Training will always be, it's not a one-off training, it will be a regular exercise. How to use the portal, how to use the data on the portal in terms of day-to-day management. And then it becomes an effective MIS. Otherwise, it just becomes a reporting tool. Data collection, checking, quality analysis. As and when you expand, when we go to the blocks and the facility level, managing huge user base will be there. Ensuring timely data to be on the portal is important so that you can release the information to the public. And electronic health records, there's been a lot of debate in the previous session. Yes, we will be link to that. We would like our Secretary of Health's office to be full of dashboards so that he doesn't have to look at files. And through this empowerment media, this is what we aim to achieve. Just to give you an idea of a snapshot, we have some provisional results for the year 2008 and 9. This is all in the public domain. How the ANCs have grown up, you can see it cluster-wise, you can see it district-wise, state-wise. All of this is available in the public domain. Have a look at it, and we are always open to feedback because feedback helps us improve the system. Now, just to give an idea of how a person can check his data, at the district when you log in, you can see the data which is entering online and you can see its previous month data. So there itself is one quality check. In addition, he can verify, find out inconsistency checks within that, and he comes out with a report, sees that. He can compare his performance vis-a-vis the earlier months and identify outliers in the span of 10 to 12 months, which are the problem data, and correct that. We have dashboards. You can identify where, this is not in the public domain yet because we're still testing it, where the performance of certain indicator has gone up or gone down. Gradually drill down to the district, the state, district, quarter, by month, and find out which data needs to be corrected. So basically we are trying to develop a culture on how people can get more evidence-based planning with the system. That's all I have to say. Thank you.